Welcome to another lecture by MedicoMedics. Chlamydia. We will begin with a general introduction of chlamydia. We will discuss normal physiology and pathophysiology, and then we will compare the two. We will continue with a case example, discuss symptoms, diagnoses, differential diagnoses, and treatment. And as always, we will end with a summary. In this specific lecture, we also have a high-yield review added, recommended for medical students. Now, chlamydia is a common sexually transmitted infection, or STI, caused by the bacterium Chlamydia trachomatis. Now, it can infect the genitals, rectum, and throat, and often shows no symptoms, however, leading to potential complications if untreated. So the causative agent is Chlamydia trachomatis, and it is a small, gram-negative bacterium that acts as an obligate intracellular pathogen, meaning it can only survive and multiply within the host cells. So what is the mode of transmission? Well, it primarily spreads through vaginal, anal, or oral sex. It can also be passed from an infected mother to her baby during childbirth, leading to eye or lung infections in newborns. Now, chlamydia is asymptomatic in many cases. About 70 to 90% of women and 50% of men with chlamydia do not experience any symptoms, which allows for the infection to spread unnoticed. But when symptoms do occur, they can include, for example, painful urination, genital discharge, and/or lower abdominal pain. Now, before we proceed to the pathophysiology of chlamydia, let us just briefly review normal physiology of the genitourinary tract. So, the urinary tract includes the kidneys, ureters, bladder, and urethra, and it's responsible for filtering waste and excreting urine. Then we have the reproductive tract. So in men, the reproductive tract includes the testes, the epididymis, the vas deferens, and the penis. In women, it includes the ovaries, fallopian tubes, uterus, and vagina. And you have here an illustration of the female reproductive system, and here the male reproductive system. We can identify several important anatomic marks here. Now, in our normal physiology, we have different protective mechanisms in place. So we have mucosal barriers. The genitourinary tract is aligned with mucosal cells that secrete mucus, and this creates a barrier against pathogens. We also have immune cells, so the tract contains immune cells that patrol for pathogens and prevent infection. Essentially, these immune cells act like security guards, ready to attack any bacteria that try to invade. Now then, let us proceed to the pathophysiology of chlamydia. Now, it all begins with the infection by the causative agent Chlamydia trachomatis. So the bacteria enter the body through small breaks in mucosal surfaces during sexual contact. Then we have the intracellular life cycle. So Chlamydia trachomatis can only grow inside cells. So it enters host cells and forms these structures called inclusion bodies, and this is where it then multiplies. So the bacteria enter host cells like parasites, creating tiny factories inside of cells where they multiply unseen. We then have the invasion of our genital and urinary tract cells. So the bacteria infect cells lining the genital and urinary tracts, causing inflammation and then damage to these tissues. Of course, following all of that, we then arrive at our inflammatory response. So the immune system responds to the infection. This will then prompt inflammation, which can cause the symptoms we then observed, like pain, discharge, or burning sensation. Now, it has been said that a lot of people, 60–70% of people, may have chlamydia, but it is asymptomatic. So it's super important to know about and be aware of the complications if it is untreated. So for example, in women, untreated chlamydia can spread to the uterus and fallopian tubes, leading to pelvic inflammatory disease, or worse, infertility or ectopic pregnancy. In men, it can lead to epididymitis, so inflammation of the tube carrying sperm, and however rarely to infertility. So to provide a more simple and easier way to remember all of this and to make it clinically relevant, because this is a lot of words, we have our illustrations here. So we have the male reproductive system and the female reproductive system. Now, what happens if we talk about the female reproductive system? We have entry of the causative agent during vaginal intercourse, okay? The bacteria are transmitted during unprotected sex. What then happens is that we have an infection of our mucosal surfaces. So these bacteria infect the mucosal lining of the vagina, cervix, especially the endocervical canal. So we're talking about this area here. And to localize, we have this cervix right here, right? We have our fallopian tubes here. We have the fundus and our ovaries right here. So the bacteria, let's change to green, enters, goes through the wall and ascends further. These pathogens can move upwards through the cervix into the uterus, where we are right now, and then proceed to ascend further into the fallopian tubes. Now, what then happens is that we will have inflammation happening, right? We will have potential damage during the process of inflammation. During the process of inflammation, we also have wound healing happening. So we could have scarring occurring here. So it is super important to have an anatomical idea, a very physical and tangible idea of what is going on. Something unseen to the naked eye, but seen under a microscope, is entering into the body. It is traveling to places where it's not supposed to go, but it is. Once it arrives at these certain locations, it will prompt inflammation, which is fundamentally a good thing. We want our immune cells to identify this threat and deal with it. However, as we've mentioned many times, a little good may be good, but a lot of good could actually become bad. So when we have this inflammatory response happening and this wound healing occurring, we can have consequences like scarring, and these tubes could be susceptible to, which are susceptible to this, could then develop scarring. And if you have a scar tissue developed here, you can then imagine in the future where a healthy sperm wants to enter and travel to the ovaries, right? Or through the fallopian tubes to connect. It will have trouble passing through the fallopian tube because this tunnel, let's say, or this road, the fallopian tube, has been scarred and damaged. So this is a very physical explanation. We're talking about something very concrete. And it is our understanding to always simplify medical pathologies to this very level. Now, the same can be said for the male reproductive system, right? So for males, what could happen? Well, during sexual contact. Bacteria enter through the urethral opening, so the tip of the penis here. The bacteria then infect the mucosal lining of the anterior urethra, leading to urethritis. And within a few days to weeks, you may then develop the classical symptoms of burning during urination, penile discharge. It's often cloudy, white, yellowish. You can have irritation and itching in the inside the penis. There is, of course, the possibility of ascending infection, right? In some cases here, bacteria can ascend the urethra and infect the epididymis, seen here, right? So it travels, leading to epididymitis, so pain and swelling in the testicles here. It's quite rarely the case that it travels to the prostate, but it could, causing prostatitis. And the same potential complication, like seen in for women, can actually occur here as well. So if it ascends and leads to this inflammatory process, same as we discussed in the female reproductive tracts, we can then have scarring in the epididymis, then leading to infertility, for example, or the risk of infertility. Now, there are a lot of different pathologies to know about and different diagnoses when we're talking about these potential consequences. Some that we just mentioned briefly, for example, is that if we get the bacteria in the female reproductive tract, right, ascending through the uterus, we could have inflammation occurring on the uterine lining. We call this endometritis. If it indeed ascends into the fallopian tubes and causes inflammation, we call it salpingitis. But the idea right now is not to memorize or learn all these different diagnoses. You will come across that as you move on in your medical studies. The very important thing I want you to take with you here is to strengthen your connection between what is unseen, right? A little organism here called something that you can't see, right? This little bacteria leads to or could lead to physical, graspable things that you can actually see. Well, this is now inside the body, so it's a bit difficult to see without correct medical instruments, but you can imagine that just like you can see your hand, these structures exist, right, inside our bodies. Now, these tubes and tunnels can become blocked. If scarred enough, they will hinder the travel of other things. For example, when we ovulate, right? And when we are intentionally trying to get pregnant, we need these roads to be clear, or as clear as possible. Excellent. Now then, let us just briefly remind ourselves the difference between a healthy genitourinary tract and a chlamydia-infected genitourinary tract. So if it's healthy, we should not be experiencing any symptoms or see any discharge. There should be normal tissue structure with no risk of infertility. When we are talking about chlamydia, we would expect painful urination, a burning sensation during urination, discharge and discomfort, inflammation, so damage to mucosal cells, and of course, a risk of infertility and pelvic inflammatory disease. So let's just briefly take a look at a case example of chlamydia. We have a 22-year-old female. She complains of pain during urination, unusual vaginal discharge, and mild lower abdominal pain. Recently, she reports that she has had unprotected sexual contact with a new partner. We do a pelvic exam and we observe cervical discharge and mild tenderness, indicative of a possible infection. We proceed to diagnosis. So we have the clinical presentation, pain during urination, discharge, abdominal pain, all suggesting chlamydia infection. We then proceed to do a lab test. So we use our nucleic acid amplification test, or NAT. And this is indeed the most accurate and commonly used test for chlamydia. We perform it on urine or swab samples. So if we do swab samples on women, we do a swab of the cervix or vaginal area. In men, we do a swab of the urethra. However, a urine test can also detect chlamydia in both men and women, so it offers a less invasive option for screening compared to a swab test. Here we just have a little reminder of the nucleic acid amplification test, step by step. So sample collection, then extraction of nucleic acids. We then do amplification, detection, and interpretation of the results. So when we do the extraction, we are extracting DNA or RNA from the sample to isolate the genetic material of any pathogens that are present. What we mean by amplification is that we add a specific primers and enzymes to target and multiply or amplify the pathogen's DNA or RNA, depending on what the pathology is, using a polymerase chain reaction or PCR. We then use fluorescent markers or probes to detect the amplified genetic material. And this will then indicate the presence of the target pathogen. And then we proceed to our results. Here we have some differential diagnoses of chlamydia. So, for example, gonorrhea often co-occurs with chlamydia, but can be distinguished by purulent, so thick yellow or green discharge. Trichomoniasis is characterized by frothy yellow-green vaginal discharge with a strong odor. What about bacterial vaginosis? Well, it is typically thin, grayish discharge with a fishy odor. No inflammation, and if we look under the microscope, we will find clue cells, and also an elevated pH. Mycoplasma genitalium causes urethritis similar to chlamydia, but is also then diagnosed with nucleic acid amplification tests. Pelvic inflammatory disease, so it presents with abdominal pain, fever, and cervical motion tenderness, and it is actually often caused by untreated chlamydia or gonorrhea. If we want to differentiate it from herpes, well, herpes simplex virus presents typically with painful genital ulcers, vesicles, or lesions, and can be confirmed with viral culture or PCR. Syphilis presents with painless ulcer or chancre in primary syphilis, a diffuse rash or systemic symptoms in secondary syphilis. So while there are some similarities between these different diagnoses, there are clear differences as well. Feel free to study this page. And now let's proceed to treatment. So we have antibiotic therapy. We have azithromycin or doxycycline. So azithromycin is given 1 gram orally, single dose, especially in pregnancy. Or we give doxycycline 100 milligrams orally twice daily for 7 days. These are first-line treatments. Now, what is the mechanism of action here? Well, azithromycin is a macrolide, so it belongs to the class of macrolides that binds to the 50S ribosomal subunit, for those who remember. And for the others, please check our cell biology lectures or our lectures on antibiotics. So by binding to the 50S ribosomal subunit, The effect of azithromycin is that it blocks the bacterial protein synthesis from happening and therefore its growth. Doxycycline is a tetracycline, so it belongs to a different class of antibiotics that targets the 30S ribosomal subunit, also halting the bacterial protein synthesis. Now we mentioned that azithromycin is especially used in pregnancy. And the reason for that is because of its safety profile. So it's safe to use during pregnancy because we haven't identified any teratogenic effects, unlike doxycycline, which can actually cause fetal bone and teeth discoloration. Also, why we kind of prefer azithromycin is because it's also given one time, right? It's a single dose. If you provide doxycycline, the patient has to take it twice daily for 7 days. So you're improving compliance by using azithromycin. So that's the pharmacological treatment. Then we have, of course, abstaining from sexual contact. So patients should avoid sexual contact until the infection is fully treated to prevent spreading to partners. And of course, testing and treating partners. So sexual partners should also be tested and treated to prevent reinfection and further spread. Just briefly, some additional considerations for prevention. Of course, safe sexual practices, so using condoms consistently reduces the risk of chlamydia transmission. Routine STI screenings, regular testing will help detect chlamydia early, especially for sexually active individuals. Public health and education, of course, awareness campaigns, always important. Partner notification and treatment, so informing and treating partners will prevent reinfection and the spread of chlamydia. So in summary then, chlamydia is a common STI caused by the causative agent Chlamydia trachomatis. It is often asymptomatic, but with potential for serious complications if it's left untreated. The bacteria lives inside the cells, damaging tissue and causes inflammation in the urinary and reproductive tracts. We diagnose it mainly with a NAT test on urine or swab samples, and this is the gold standard for detecting chlamydia. We treat it with antibiotics, so azithromycin preferably, or doxycycline. And of course, we promote testing and treatment of partners to prevent spread. And here is our review with high-yield information, especially for medical students or anyone preparing for an exam. Feel free to pause and study. And that's the end of this lecture. Thank you for listening. If you liked our video, please like and subscribe for more videos.